So let's now go through the questions. There's going to be 3 questions here that we want you to answer, and then we'll have Sudhir take over and give you some insight. It's really an area that I know a lot of people struggle with because there's only a few centers around the country that really are into pulmonary hypertension. But you'll see these patients, you'll need to know what to do with them, and that's what Sudhir is going to give you the information for. So the first one, you have a 24-year-old woman who comes to see you because her mother and aunt both have pulmonary arterial hypertension due to a BMPR2 mutation. So now we're getting into the genetics, which is important in this area. Which of the following is correct regarding the heritable pulmonary arterial hypertension? Autosomal recessive inheritance, more common in males than females. If she has a gene, there's about a 20% chance she'll develop pulmonary hypertension. The prognosis is better than in idiopathic pulmonary hypertension. The age of onset is similar across all family members. So go ahead and let us know what you think the correct answer is concerning this patient who has a BMPR2 mutation. Okay, I think you'll have some work, Sudhir. Mm-hmm. Okay, next question. For which of the following groups does pulmonary arterial hypertension occur with sufficient frequency to warrant periodic screening? So these are patients who do not have a diagnosis, but they have a predilection for developing pulmonary hypertension. HIV positivity, scleroderma, previous splenectomy, obstructive sleep apnea, or systemic hypertension. Okay, next one. So this is a good one here because this has some cath findings, and you're going to certainly be asked to kind of look over cath traces and Doppler echo traces and make some clinical decisions based on that. So this patient with pulmonary hypertension undergoes acute vasoreactivity testing in the cath lab using inhaled nitric oxide. So her baseline PA is, the first one is the systolic of 80, the second one is the diastolic of 35, and the mean is the last number, so that's 50 millimeter of mercury. Her wedge pressure is 10, cardiac output is 4, so that gives her a pulmonary vascular resistance of 4 Wood units. With nitric oxide, her PA mean pressure dropped to 44, her wedge pressure was 12, her cardiac output was 4.2, and her pulmonary vascular resistance was 7.6 Wood units. And I'm sure Sudhir is going to go over these calculations with you because you should know how to calculate pulmonary resistance. Which is the correct regarding treatment decisions based upon these catheterization findings? Verapamil, amlodipine, you would not use calcium channel blockers. No therapy is needed. Calcium channel blockers should always be started in the hospital setting. So put in your best answer here. Okay, I think you need to give them your knowledge.
Well, good morning, everyone, and welcome to Rochester. Okay, so these are the learning objectives. I'm going to keep it very board-focused. So we're not going to review new trials, new studies going on, new combinations. We're going to focus on the basics and have you prepared for this exam. There will be a handful of pulmonary hypertension questions which come up. I recertified back in 2013, and there were about 5 questions on the recertification exam relating to this subject. So our learning objectives for today are to describe the underlying physiological principles and different etiologies, develop a comprehensive approach to diagnosing, determining the etiology, and evaluating the patient with PH, including interpretation of hemodynamic findings, and develop appropriate management strategies, including selection of medical therapies. So how does PH present? Sometimes with symptoms, often dyspnea, sometimes syncope. Quite often, the patient has had an echo for other reasons, and an incidental finding of elevated RV systolic pressure is noted. And sometimes as part of screening tests for connective tissue disease or patients with a family history of pulmonary hypertension. So our first learning objective described the underlying physiological principles and etiologies. So the definition of pulmonary hypertension is quite clear. Basically a mean PA pressure of greater than 25. And when we think about the PA pressure, this is determined by the cardiac output through the pulmonary vascular bed, or pulmonary blood flow, the back pressure on the circuit, which is the wedge pressure effectively, and then the resistance of the pulmonary vasculature. And as Dr. Nishimura mentioned, you should all be able to calculate the pulmonary vascular resistance, and that's given in Wood units by this formula, which is the difference between the mean PA pressure and the mean wedge pressure divided by the cardiac output. And you can make it the pulmonary vascular resistance index if you divide by the cardiac index. And the difference between the mean PA pressure and mean wedge pressure is known as the transpulmonary gradient, and the normal of that is less than 7. So cardiac output goes through the left side and the right side of the heart. It's one circuit, and you might hear the term pre-capillary pulmonary hypertension, and that basically is characterized by elevated pulmonary vascular resistance and encompasses these different groups, and I'm going to review those groups with you shortly. But group 1 is idiopathic familial pulmonary hypertension, group 3, hypoxic lung disease, group 4, chronic thromboembolic pulmonary hypertension, and group 5 is other miscellaneous categories. And the point about it is that all these are pre-capillary. Now, the much larger group of patients we see are the post-capillary pulmonary hypertension, and that's effectively left side heart disease. So any cause of elevated filling pressures on the left side, if sustained for long enough, will give rise to post-capillary pulmonary hypertension. And quite often, in patients who have had chronic wedge pressure elevation for some period of time, we'll see this combined pH, which is basically pre- and post-capillary. And the reason that happens is that over a certain period of time, with chronic wedge pressure elevation, they'll effectively end up being elevated pulmonary pressures and then remodeling, adverse remodeling of the pulmonary vascular bed, which will result in sort of like a pre-capillary picture as well. Now, a caveat here, there's another category which is kind of classified under group 1, which is pulmonary veno-occlusive disease, which is a slightly different entity, and we'll mention that as well, a little bit more detail later. So all pulmonary hypertension, whether it's arterial or venous or combined, typically you'll have a pulmonary artery systolic pressure greater than 35 and a mean pulmonary pressure of greater than 25. What's different is the pulmonary vascular resistance and the wedge pressure. So in precapillary or pulmonary arterial hypertension, we will have a wedge pressure which is less than 15. Essentially, it's defined by a normal wedge pressure. And with that, the pulmonary vascular resistance will be greater than 3. In pulmonary venous hypertension, or driven by left-sided heart disease, we'll typically have a wedge pressure greater than 15. And the pulmonary vascular resistance, as a result of that, will start off being less than 3. But if left long enough, we have this combined picture where we'll end up, obviously, with a wedge pressure greater than 15 and a pulmonary vascular resistance which is greater than 3. Now, pulmonary venous hypertension evolves to include the development of pulmonary arteriopathy. And what you'll see initially is that when we get pulmonary venous hypertension, and that results in an elevation in pulmonary systolic pressure, but the pulmonary vascular resistance is normal. Then we get a reactive picture where we have reversibility of the pulmonary vascular resistance. In other words, when we test these patients in the cath lab, we can bring the PVR down with giving vasodilators, quite often nipride. But when you've got chronic remodeling, typically we'll end up with a fixed PVR. Now, just add a caveat there, that is fixed in the cath lab when we give vasodilators, but many of these patients with heart failure, for instance, if they then go on and end up with chronic unloading therapy, for instance, like LVAD, then we will see reversal of that pulmonary vascular resistance. So it's fixed at that time, but chronic unloading will sometimes change some of that remodeling. Now here's the World Symposium most recent classification of pulmonary hypertension. Now group 1 includes idiopathic, familial, and then a variety of different diseases which are associated with pulmonary hypertension. And the reason for putting all of these into group 1 is because they share the hemodynamic findings and the response to therapy. That's what defines group 1. So it doesn't matter if it's idiopathic or related to connective tissue disease. The fact is, hemodynamically, in the cath lab and in responding to pH-specific therapy, they will behave the same. Group 2 is left-sided heart disease, as we mentioned, characterized by elevated wedge pressure. And group 3 is hypoxic lung disease, any interstitial lung disease, COPD, sometimes associated with some elevation in PA pressures. Group 4 is chronic thromboembolic disease, which can be proximal, distal, or sometimes related to other infiltrative conditions in the lungs. And then group 5 is a whole bunch of miscellaneous type diseases which can cause elevation in pulmonary pressures. So for evaluation, we want to try and develop a comprehensive approach, our learning objective number 2. So the clinical findings are fairly obvious: shortness of breath, fatigue, chest pain in 20 to 30% of patients, syncope, usually a bad sign, lower extremity edema. And when we look at clinical presentation, we try and classify the patient on the WHO functional status. Now, this is very similar to New York Heart Association class for heart failure. Class 3, marked limitation with dyspnea, chest pain, fatigue, or presyncope during less than ordinary activity. And class 4 is severe limitation. The presence of syncope defines a class 4 patient. So by definition, if somebody presents with syncope, even though they might seem reasonable otherwise, they're class 4. Clinical findings are basically those of right-sided heart failure. You might appreciate an RV lift. The JVP is typically elevated. There may be hepatomegaly, the presence of a pulsatile liver, ascites, or edema. P2 is often loud. There may be a right-sided S3 or S4. Sometimes a tricuspid regurgitant murmur. Quite often you don't really hear a murmur. Or a pulmonary regurgitant murmur as well. And then there's a variety of other clinical findings which will pertain to whatever condition the patient has. So for instance, somebody with congenital heart disease might be clubbed, the presence of fine crackles, interstitial lung disease, features of scleroderma, sometimes evidence of varicose veins or stasis ulcers might lead you to suspect thromboembolic disease. And then portopulmonary findings may be related to the presence of liver disease as well. The chest X-ray shows characteristic features including peripheral hypervascularity, enlarged central pulmonary arteries, presence of RV enlargement. The ECG in severe PH will demonstrate right axis deviation and signs of right ventricular hypertrophy with strain, and sometimes a P pulmonale from right atrial enlargement. Pulmonary function tests are typically characterized by a decreased DLCO, and in fact the interpretive comment may be suggestive of pulmonary vascular disease if all the other findings are reasonably normal. So the first question when we're evaluating these patients is to ask ourselves, is it group 1? Because that's going to determine how we approach the patient from a therapeutic standpoint. So are there risk factors for group 1? So is there, for instance, connective tissue disease, family history, and so forth? We want to exclude group 2 and group 3, and the relevant investigations are seen here. Obviously, we want to exclude group 4 with a VQ scan, ventilation perfusion study, and then the miscellaneous conditions usually present in other ways. So the investigative track, if you will, is fairly obvious in the sense that everybody's going to get a history, physical exam, chest x-ray, an ECG, and an echo. And echo really is the best screening tool for pulmonary hypertension. It'll give us information on RV systolic pressure, the state of the right ventricle, the state of the left ventricle, presence of left heart disease. Typically, a Doppler estimated RV systolic pressure greater than 40 warrants further evaluation in a patient with unexplained dyspnea. Echo is useful for RV size and function. There are a variety of quantitative measures which we can employ. The presence of a pericardial effusion is a very poor prognostic sign in the presence of severe pulmonary hypertension. Cardiac MRI or CT scan are very useful for quantification, particularly RV volume. When we're assessing patients for transplant, patients with pulmonary hypertension, that's one of the main tests we use is to look at RV size, and CT and MR imaging are excellent for that. A ventilation perfusion scan is very useful for ruling out chronic thromboembolic disease. If it's positive, we will use that to then move on to either a pulmonary angiogram or a CT angiogram, coagulation studies to look for predisposing coagulopathies. It's important to bear in mind, though, that only 3 to 4% of patients with an acute pulmonary embolus actually develop thromboembolic disease, and 50% of these patients actually don't have any history of acute PEs. So the absence of a history doesn't rule out the possibility of this condition being there. Normal or very low probability generally excludes the diagnosis, so certainly here at Mayo, we still use the ventilation perfusion scan as a screening tool for new patients who are presenting to the pulmonary hypertension clinic. And a high probability scan definitely warrants a pulmonary angiogram or a CT angiogram. Increasingly, we're doing CT angiograms, and in fact, some of our younger cardiac surgeons are getting more familiar, comfortable with that approach than the traditional pulmonary angiogram. Non-diagnostic VQ or lung disease, you have to use your clinical judgment and index of suspicion. Pulmonary function tests and overnight oximetry are useful for looking at lung disease. Obviously, arterial blood gases, gas exchange studies, overnight polysomnogram, looking for sleep disorders. In COPD, 50% of patients with an FEV1 less than 24% and referred for lung volume reduction surgery had pH, but it's generally mild. So most patients with lung disease don't have very elevated pressures. And severe pH in these patients is relatively rare. And again, in interstitial lung disease, 40 to 60% have some degree of pulmonary hypertension, but mild in the majority. And obstructive sleep apnea is a clear association, but generally modest pH, even in a very severe obstructive sleep apnea. And then other conditions which may cause pH, you have to use a variety of screening tests if you suspect that those conditions are present. HIV is one of the causes of pulmonary hypertension, and we generally, for new patients, do an HIV test in the clinic. Anti-nuclear antibody if you suspect scleroderma or connective tissue diseases, and obviously liver function studies for portopulmonary. And then most patients should have a 6-minute walk, cardiopulmonary exercise test, BNP measurements, which are useful as a baseline and in order to follow patients and look at prognosis. And anybody with severe PH in whom you're contemplating treatment needs to have a right heart catheterization. And a vasodilator study, if it's suspected group 2, then you might consider volume loading or exercise on the cath lab table to try and give you more information. So the right heart catheterization is required for a diagnosis, and you cannot start pH therapy without it. So if there's a question on the board suggesting that you can give, say, bosentan to a patient who presents de novo and hasn't had a right heart cath, then you're not going to do it. You're going to get the right heart cath first. Number one, it confirms pulmonary pressure, and as I said previously, mean PA pressure greater than 25. You can measure the cardiac output. If there's significant tricuspid regurgitation or a shunt, then you want to use the FIC formula. Gives you a measurement of wedge pressure, or if there's any doubt, the LV end diastolic pressure, which should be less than 15. And we can calculate the pulmonary vascular resistance. Normal is less than 3. And if there's suspicion of heart failure with preserved ejection fraction, volume or exercise can be done on the cath lab table. And as I mentioned earlier, the PVR is the difference between the mean PA pressure and wedge pressure divided by the cardiac output. So the role of vasodilator testing. So this is critical. What defines a positive response? And a decrease in mean PA pressure by greater than 10 millimeters of mercury, or a decrease of mean PA pressure to 40 millimeters of mercury or less, and the cardiac output doesn't get worse. You can use prostanoids, inhaled nitric oxide, or adenosine. They're comparable. In our lab, we use inhaled nitric oxide. We used to use prostacyclin. Really no difference in terms of the data generated. But nitric oxide has become a little bit more useful in the sense that if there's a very dramatic response to it, almost defines a patient who's going to do well with PDE5 inhibition. Only 10% of patients who undergo vasodilator testing are positive. It might indicate a subgroup of those who actually respond to calcium channel blockers. And this is important because calcium channel blockers are cheap and easily available compared to the pH medications, which are expensive and a little bit more difficult to get. So the fact is, of those 10%, if you look at some of the older studies, maybe a quarter to a third might actually respond to calcium channel blockers. So that 10% may still end up on pH-specific medications. If there's marked elevation of the wedge pressure or pulmonary edema with vasodilators, you might suspect pulmonary veno-occlusive disease or left heart disease. And then management strategies for patients with PH, including selection of medical therapies. So let's get some of the easy ones out of the way. So group 4, thromboembolic. If the location of the chronic thrombi are amenable to surgery, then you want surgical thromboendarterectomy. Pulmonary balloon angioplasty is increasingly used in more peripheral lesions in many centers. The Japanese pioneered it. In fact, we've developed a program here for that. And then riociguat, which is a soluble guanylate cyclase stimulator, has become approved for inoperable or residual thromboembolic pulmonary hypertension. With group 3, obviously you want to treat hypoxia, judicious use of diuretics for RV failure, and consider referral for lung transplant. And for the purposes of this exam, do not treat with pulmonary hypertension specific medications. So somebody with lung disease, modest elevation of pressures, you want to use oxygen, diuretics, etc., but no bosentan, no sildenafil. And some of those patients do actually respond to those medications, but there is a risk in lung disease that by giving pH-specific medications, you actually worsen the VQ mismatch and increase blood flow to bad areas of lung rather than good areas of lung. So that's the rationale. So no pH-specific therapy for these patients. This is just a graph to show who of these lung disease patients, this is more for your practical sort of use really, but the greater the degree of hemodynamic compromise, the more likelihood of response to therapy. The worse the lung disease, it's unlikely that these patients will respond to pulmonary hypertension-specific medications. So with group 2, or left heart disease, we obviously want to treat the primary condition. So if there's heart failure, preserved ejection fraction, you want to do what you can to control blood pressure and so forth, bring down the wedge pressure, treat hypoxemia or sleep apnea. The RELAX study, which was published a few years ago, and Dr. Redfield was the author on that study, showed no benefit for phosphodiesterase 5 inhibitors in these patients with heart failure, preserved ejection fraction, and PH. Having said that, there are a subgroup of these patients who respond. I follow a number of them in the clinic who actually enrolled in RELAX and did very well with the decrease in their PA pressures, but when looked at in its entirety, this was a negative study, and these drugs are not recommended. There are some investigational studies using inhaled nitrites, and there may be benefit in heart failure reduced ejection fraction, or for both PDE5 inhibitors and riociguat, the soluble guanylate cyclase stimulator. So for group 1, we're dealing with a panvasculopathy characterized by cellular proliferation, decreased apoptosis, vasoconstriction, intimal hyperplasia, and eventually the development of plexiform lesions. These days, we don't see so much of that because patients tend to present earlier. They've been short of breath, they've had echoes, so the classic plexiform type lesion is not so frequent. With group 1, the female to male ratio is 3:1. Mean age at diagnosis is 37. There's some familial component. 6 to 10% of all PH patients have some degree of heritable PH. The BMPR2 mutation is autosomal dominant but incomplete penetrance. Connective tissue disease, typically systemic sclerosis or SLE, quite frequently associated, although I've seen it associated with most of these connective tissue diseases. Portal hypertension, liver transplant candidates. If a liver transplant patient has significant pH, it has to be treated aggressively pre-transplant. The mortality going into liver transplant with untreated pH is over 50%. So that's a very important point. But they actually respond to therapy quite well, hence the group 1 classification. And then there's a variety of different drugs and substances which can cause pH group 1. So when we think about pH, we think about pre-symptomatic or compensated, symptomatic or decompensating, or declining or decompensated. Symptoms progressively get worse as we move from the early stages to the late stages, and with that, the pulmonary vascular resistance increases all the way through. Now, the PA pressure keeps increasing in parallel with the PVR, and when the right ventricle fails, actually the PA pressure declines. So in more advanced PH, the PA pressure may not be as high as you think it should be. Severe right heart failure. The cardiac output stays stable for a period of time, but then also gradually starts to decline. And the right atrial pressure is your clue to severity of the disease. So the right atrial pressure, if it's elevated, really tells you that this is a patient who is decompensated and declining. Because, as I mentioned, the PA pressure can be deceptive. You can have this point here and this point here, where the PA pressure are basically the same. So you really want to look at right atrial pressure as the number which helps you define how severe the patient actually is. Predictors of poor prognosis include a diminished 6-minute walk distance, the presence of a pericardial effusion, RA pressure greater than 20 or cardiac index less than 2, class 4 symptoms, syncope or rapidly progressive symptoms, and high BNP or NT-proBNP as a manifestation of RV failure and volume overload. There are adjunctive treatments we can give, including oxygen Warfarin is somewhat contentious, as I'll illustrate in the next couple of slides. These ancient studies, one from Fuster when he was here at Mayo in 84, and one from Dr. Stuart Rich, suggested benefit of giving anticoagulation. But remember that these studies were really in an era where there was no treatment, apart from calcium channel blockers. So everybody got warfarin, and a subset of those clearly benefited, and the overall survival was better. Diuretics for RV failure, digoxin may be beneficial, sometimes can be harmful if arrhythmias develop. We want to avoid pregnancy in these patients, as there's a 30 to 50% risk of maternal death. Now, coming back to warfarin, when we look at a subset of patients with connective tissue disease, they clearly do better without anticoagulation. And in this study, the comparer study, the idiopathics did better with anticoagulation. But then when we look at another database, the REVEAL registry data, clear harm with connective tissue disease, and with idiopathic, no significant difference, but a tendency to, no significant difference, basically. But so that evidence is conflicting. So many of us now do not routinely prescribe warfarin in the presence of other pH-specific medications. I think if there's a specific reason to prescribe it, it's probably reasonable to give it. But I've seen 2 or 3 patients with idiopathic pulmonary hypertension on warfarin who have died from hemoptysis, which cannot be easily controlled when the PA pressures are very high. So I don't think there'll be a question on this because it is so contentious. Calcium channel blockers, for patients who respond, they do remarkably well. Survival advantage. Now bear in mind, old study, only 17 responders compared to the registry data. And generally, the drugs we use are nifedipine, amlodipine, or diltiazem, not verapamil. So verapamil should never be used in pulmonary hypertension. Studies have demonstrated benefit in group 1 with targeted therapy, and group 4, but the pH-specific medications not readily extrapolated to group 2, 3, or 5. We want to try and obviously improve functional capacity and decrease symptoms, improve hemodynamics, and delay progression of the disease, hopefully resulting in improved survival. And the 3 main modes of therapy utilize the 3 pathways which affect the pulmonary vascular bed: prostacyclin pathway, the nitric oxide pathway, and the endothelin pathway. Calcium channel blockers act down here, direct vasodilators. And here we'll have prostacyclin and its analogs, augmenting the prostacyclin pathway. Here we'll have phosphodiesterase 5 inhibitors, making available more nitric oxide in the pulmonary vascular bed, and soluble guanylate cyclase stimulators, riociguat. And then here we will block our endothelin receptors to diminish vasoconstriction and proliferation. So the prostacyclin pathway, PGI2, this results in vasodilatation, antiproliferation, and inhibition of platelet aggregation. And the rationale for giving it is that prostacyclin production in these patients with pulmonary hypertension is decreased. The first drug, epoprostenol or prostacyclin, was shown in the early, during the 90s. Study was published in the early 2000s to improve exercise capacity, quality of life, reduces the PVR more than the actual PA pressure, which only goes down a little bit, and the benefits persist over the long term with a survival benefit. So this therapy has sustained, and there are a number of analogs, including treprostinil. There are a couple of oral agents now, oral treprostinil or orenitram and selexipag, which are really only seen usage in the last couple of years. I doubt you'll get any questions on these oral agents. Note that treprostinil has a significantly longer half-life than epoprostenol and is given through a Hickman line. So be aware of catheter-related sepsis. Subcutaneous delivery is often associated with pain in about 30 to 40% of patients, which necessitates actually discontinuation of this approach. The inhaled agents, inhaled prostacyclin analogs, can result in cough but are effective and useful for some patients. The endothelin pathway, endothelin is a vasoconstrictor and a smooth muscle proliferator and causes vascular remodeling. Levels are elevated in pulmonary hypertension, more so in idiopathic and familial than in Eisenmenger's or normal. Number of side effects to be aware of these agents. The original agent, bosentan, which first came out, 10% of these patients developed LFT abnormalities, and if they're still on that drug, then monthly LFT testing is mandatory. Also has a number of important interactions, including with sildenafil, glyburide, increased bosentan hepatotoxicity, and this actually same thing with cyclosporin and bosentan. Oral contraceptives are less effective, so barrier methods are recommended. And with ambrisentan, which came out a few years later, LFT monitoring not required, and the same with macitentan, which is probably the more widely used agent now as an endothelin receptor antagonist. LFT monitoring is not required. The nitric oxide pathway, we have our PDE5 inhibitors and soluble guanylate cyclase stimulators. So nitric oxide, as you know, is a potent vasodilator and antiproliferative, activates cyclic GMP, and PDE5 inhibition results in enhancing cyclic GMP-dependent vasodilatation. Two agents available are sildenafil and tadalafil, both of which acutely improve pulmonary hemodynamics. The hemodynamic benefit is sustained, and studies have demonstrated improved functional capacity. Side effects to be aware of include headache, epistaxis, diarrhea, reflux, sometimes visual and hearing changes as well. And then the latest approach is with these soluble guanylate cyclase stimulators. Riociguat, or DEMPAS, is the agent, and that's been shown to improve pulmonary hemodynamics, the 6-minute walk test, and delay clinical worsening, and a specific role in thromboembolic pulmonary hypertension. So these agents all improve parameters, including some modest decrease in mean PA pressures, a decrease in PVR, and decrease in right atrial pressure. The choice of dose, 20 TID, was based on the fact that in the original study, 3 different doses were tried, 20 TID, 40 TID, and 80 TID, and there's really no significant difference. So we've gone for the lowest useful dose, and that's 20 milligrams 3 times a day. Riociguat has been shown to be beneficial in group 1. This was published a few years ago. Compared with placebo, however, the criticism of this study at the time was that it wasn't compared with the established medications, the PDE5 inhibitors, and one wonders actually whether there would have been that much difference if that had been the case. And in thromboembolic pulmonary hypertension, as I said, this agent has found a specific role. It improves 6-minute walk distance, PVR, decreases BNP, and improves WHO class. No impact on time to clinical worsening. They've all been used in this condition, but these days most centers and most clinics will probably prescribe riociguat first on the basis of this study, which included a subset of patients with thromboembolic pulmonary hypertension. So when we look at our treatment algorithm, obviously everybody will undergo acute vasoreactivity testing. If they're positive, you may try oral calcium channel blockers and see if they do anything. If there's a response, you would maintain that therapy. If there's no response, then you move to using the other agents available. Generally, in patients who are less sick, you would want to go with the oral agents, phosphodiesterase 5 inhibitors, and perhaps endothelin receptor antagonists before moving to parenteral approaches or oral prostanoids. Reassess, consider combination therapy, consider investigational protocols. So higher risk patients, particularly those presenting with right heart failure, elevated RA pressure, you'd really want to move to an intravenous epoprostenol or analog. Perhaps you might consider an inhaled agent. the increasing tendency now is for upfront combination therapy to try and tackle all three pathways at the same time. In a previous era, we would generally stick to one or two medications before and wait for worsening, but I think the thinking now is to try and impact as much as possible early. So the treatment goals, we want to try and get to functional class 1 or 2, normalize RV function and hemodynamics, improve 6-minute walk to greater than 440 meters, improve our exercise study to greater than 15 VO2, and decrease BNP and NT-proBNP. There's a variety of studies which have been done in different combinations. The different companies which make these medications tout their study as showing the best approach, but really, I think it doesn't really matter. I think we want to try and, if we're going to combine therapies, pick an agent from each group and go with that. Balloon atrial septostomy has a role in very severe right-sided failure. It creates a right-to-left shunt, and basically we're allowing left ventricular filling. If you think about it, the right ventricle is big, baggy, and weak, and is not pushing blood through to fill the left ventricle. And the septostomy allows LV filling, but obviously you're going to get systemic desaturation. And it's useful if there is severe PH refractory to medical therapy. When the right atrial pressure is very elevated or the O2 saturation is markedly diminished already, then have to be very cautious. Lung transplantation is an option for severe end-stage disease. Heart-lung, if there's really severe RV failure. ECMO can be used as a bridge. We've done that here on several occasions. In fact, there's a patient we have in our ICU at the moment waiting on ECMO for heart-lung transplant. And we might consider if there's symptomatic progressive disease despite optimal treatment with prostacyclin. Timing is key. Remember that any transplant involving lungs, you're dealing with a 50% 5-year mortality. So you want to time it so that patients get the benefit of the transplant and it's not done too early. In general, PAH patients survive better if they get through the perioperative period with an average 8.8-year survival. So with that, I will finish, and I think Dr. Nishimura is going to come up here and go through the questions.
Let's give him a round of applause.
Yeah.
Have a seat, Sudhir. Beautifully done. This really is an area that a lot of us plain old cardiologists aren't all that familiar with, and I always give Sudhir a call with many of the patients. But as you can see, there's targeted therapies now, more all the time, that are really beneficial in treating these patients. So I think the onus is up to you to understand the pathophysiology, the workup, and some of the treatments available. So let's go ahead with this, back to this first question. The 24-year-old woman comes to see you because her mother and aunt both have pulmonary arterial hypertension due to a BMPR2 mutation. Okay. Which of the following is correct regarding this heritable pulmonary arterial hypertension? Autosomal recessive inheritance, more common in males than females. If she has the gene, there's a 20% chance she'll develop pulmonary arterial hypertension. The prognosis is better than idiopathic pulmonary arterial hypertension. The age of onset is similar across family members. So they're going to try to get 95% correct here. I don't know if they can do it. We'll see. Ooh,
Well,
82. Not bad.
not bad. Better than before.
Okay, do you want to, why don't you put Sudhir's next slide on, and do you want to talk about the hereditary aspects of pulmonary arterial hypertension?
Well, there's a number of genes which have been described. Some have a clear autosomal dominant pattern, and in fact, there's a few generation families we've seen in our PH clinic where lady would come in with a clear history. Mother died at the age of 30, uncle died at the age of 30, and so on. But it's definitely more common in males than females. The BMPR2 is autosomal dominant with incomplete penetrance. 20% lifetime risk if the gene is present. So having the gene doesn't necessarily mean that PH will definitely occur, but there is a 20% lifetime risk. And prognosis in many of these familial cases may be worse than idiopathic. And the age of onset definitely varies across family members. We've seen patients presenting as late as age 50 and as young as age 18 with a heritable history. So I think the genetics is still being worked on. In fact, my colleague Bob Franz, who's head of the PH clinic here, is working on NIH, is part of an NIH study looking at the influence of hereditary in pulmonary hypertension, a variety of different conditions.
So in your own patients, do you recommend genetic screening when they come in?
Well, yes, I do. And I'll give you an example. There's one young woman I looked after who's the one who actually died of hemoptysis. She was anticoagulated, and she had a very clear history, and she had 2 young children, both boys. And when she first presented, we sent her off to get tested, and because in her case it was probably X-linked, the boys didn't have it. But I think if the patient gives you a clear family history, and she had a maternal uncle who died young and a mother who had died young, and so clear genetic history, we would recommend genetic testing.
And would you do anything differently in the person who has a positive, in the first-degree relative who might have a positive test?
Well, that's a good question, because up until a certain point, their pulmonary hemodynamics are normal.
Yeah.
Okay? And the question is when. So I would recommend, as it's generally rarer to have it as a child, but probably from about the age of 12 or 13 onwards, at least get an echo once in a while. So maybe a 13-year-old, you get an echo and it's normal, then you might want to repeat it at age 15, 18, something like that. So common sense, I think, should dictate it. There isn't really any set guidelines for how frequently screening should occur, but screening should occur in patients who have that hereditary.
But I think your concept that you had pointed out is that if you could treat them before the onset of the irreversible pulmonary hypertension,
Yeah.
they'll probably be better off in the future, right?
Exactly. Yeah.
And do you want to comment about that initial study of pulmonary hypertension and calcium channel blockers and how that might just be identifying an earlier group of patients?
Yeah, no, that's exactly right. I mean, I think that of that ancient study, the one where the responders did very well, only about 25% of those patients who responded in the cath lab actually benefited, and the N value was relatively small. But that, in retrospect, would probably identified an inherited group.
All right, let's go to the next question. For which of the following groups does pulmonary arterial hypertension occur with sufficient frequency in the person who does not have pulmonary hypertension to warrant periodic screening? Positive HIV, scleroderma, previous splenectomy, sleep-disordered breathing, or systemic hypertension?
And this is going to be 95%. Yeah.
Yeah, you can clap for yourselves. All right.
So,
any discussion?
well, I think that it's periodic screening is the key word. So HIV, definitely associated in about 20 to 30% of patients with HIV will have pulmonary hypertension, but that's an initial screening. Scleroderma, we see a lot of scleroderma patients in our PH clinic and work very closely with our rheumatologists. These patients may start out with relatively normal PA pressures, but as their disease progresses, there's a pretty good chance that they'll develop some degree of RV systolic pressure elevation. So generally, we recommend an annual echo for these patients. If they start becoming dyspneic, it's sometimes difficult to separate out the fact that scleroderma is also associated with interstitial lung disease. So their dyspnea may be coming from interstitial lung disease, may also be coming from right-sided heart failure and pulmonary hypertension. So periodic screening, we will find that on average about 30 to 40% of a scleroderma cohort will develop significant PH at some stage in the course of their disease.
And you screen with a?
With an echo.
Okay. All right, last one. So there's actually a number of questions about the caths, so let's go over this question.
All right, okay.
Patient with idiopathic pulmonary artery hypertension undergoes acute vasoreactive testing in the cath lab. Okay. So the baseline mean PA was 50, the wedge was 10, the cardiac output was 4, and by Sudir's equation of the calculation for resistance, it was 10 Wood units. And you should be able to calculate that. With nitric oxide, the PA fell to 44, the wedge was 12, the cardiac output was 4.2, the resistance was 7.6 Wood units. Now, this is going to have effect on your treatment decision, so let us know what you would do. Verapamil, amlodipine, calcium channel blockers are not appropriate. No therapy needed. Calcium channel blockers should always be started in the hospital setting.
That's pretty good. So we're at 88%. I was hoping for 95, but, you know.
Sorry.
Yeah. So let's just go through these different options. Verapamil, as I said, is not recommended. It really is not effective in this condition.
Actually, so can you speculate why? Yeah, I'll tell you the story of
You tell me the story. I don't know. It's just one of these pieces of wisdom which we're taught from an early age.
The piece of wisdom is when calcium channel blockers first came out, verapamil was the first one that was used, yeah. And it was given IV in the cath lab, and everybody died. So that was a bad drug to give. And probably the reason is it caused acute vasodilatation and decreased systolic function of the right ventricle. Right. We actually had, I mean, I remember some of the, at least one or two of those instances. Yeah. So verapamil is not used.
Yeah. Amlodipine, if the patient was responsive, could be a good choice. But if you look at the actual pressures there, so the baseline pressure, mean PA pressure is 50. And then after nitric oxide, it goes down to 44. So it doesn't decrease by greater than 10. And it doesn't go down to below a mean of 40.
So there were like 3 questions. Do you need both of those things or just one of them?
One of those things.
So you need just one?
Just one of those things.
So either a decrease in 10 or the mean coming less than 40.
Correct.
Okay.
And so this patient doesn't meet criteria for calcium channel blockers on the basis of the hemodynamic information given. And when they're started, we typically go with amlodipine because it's just easier to dose and easier to give. Diltiazem is an alternative if there are specific side effects like peripheral edema, which are worse with one than the other. And they can be given as an outpatient. It doesn't require hospitalization unless there's severe hemodynamic compromise. And in that case, you probably wouldn't be thinking about calcium channel blockers anyway. You'd be thinking about parenteral agents if there's severe right heart failure. No therapy is needed. The cardiac output actually is not preserved here. It's 4. I would say that's a somewhat decreased cardiac output. And I just answered that question. Calcium channel blockers should always start in the hospital setting. So we typically give them if we're going to give them as an outpatient, see how the patient gets on. For this patient, the RA pressure, we don't have an RA pressure, is that right?
We do not have
We do not, but we would probably start off with an oral pH-specific agent, probably sildenafil or an endothelin receptor antagonist like macitentan. Equally good choices as first agent to start treating pulmonary hypertension. Most of us, I think, go with the PDE5 inhibitor first and follow up with addition of an ERA. That's the typical practice these days, is to go with those two agents. They're easier to give, they're oral, well tolerated, and then we'd move to prostanoids depending on the degree of response we see in follow-up. So the first strategy, first agent, see the patient back in 2 or 3 months, review, consider adding a second agent, and then follow up again and consider adding third agent depending on RV function, estimated pressures, and so forth.
Now, your algorithm, and this will just be to reiterate it, had shown you've got a low-risk group that you're talking about now,
Yeah.
and then a high-risk group where you might want to go combination therapy or IV prostanoids or something
Correct.
like that. Tell them how to differentiate low and high risk.
Well, in fact, the next question, I believe, addresses that. So the high-risk group are basically the group who have already got established right-sided heart failure. So right atrial pressure gives you a lot of information. So if somebody presents and the RA pressure is greater than 15 to 20, then you really want to consider more aggressive therapy with an intravenous agent. And typically we go with intravenous treprostinil or intravenous prostacyclin. The new formulation for that is called Velitri, which is temperature stable. And obviously, we couple that with the visual appearance of the right ventricle on echo as well and right ventricular size. So we would initiate that and then add oral agents as well. And with that approach, you're giving the most powerful agent first and most effective agent probably, and following it up with controlling the other two pathways as well.
So it's really not the degree of pulmonary hypertension as much as the response of the right ventricle.
Correct.
That you're using to
Well,
differentiate
you see,
that.
it's not about the pulmonary pressures. It really ends up being about the right ventricle.
Yep.
That's what we have to understand in the treatment of this condition, is it's all about the right ventricle. It's the failure of the right ventricle that results in all the morbidity and mortality associated with pulmonary hypertension.
So I think with that last statement, that kind of summarizes what you need to know about these patients, but that right ventricle is critical importance, and as Sudhir said, just looking at the neck veins and getting a right atrial pressure is going to tell you an awful lot about these patients.